Good afternoon. I'd like to speak today about a new approach to the treatment of infectious disease, and that's by leveraging the innate immune system through the use of innate defense regulators. There are a couple of advantages to leveraging the innate immune system. The first is that the therapy becomes intrinsically agnostic. In other words, it's a very broad spectrum therapy. It doesn't really matter what the bacterial infection is that turns on the innate immune system. We can still modulate the downstream response of the innate immune system. Moreover, innate immunity has been around for millennia targeting bacterial infections, and this suggests that an approach that harnesses the innate immune system would be very complementary to the existing use of antibiotics, and the combination of antibiotics in these innate defense regulators may be extremely powerful in the context of antimicrobial resistant disease. Before we begin the presentation, we do have to make the normal comments about forward-looking statements, which is listed here in all of its detailed legalese, and I'll allow people to read that at their leisure. Before we begin today's discussion about the innate defense regulators specifically, it's perhaps worthwhile to start by talking about how it might be possible to leverage the innate immune system in a more general sense. So what is innate immunity? Innate immunity is a type of immunity that's the most ancient. It's been around, as I said earlier, for millennia and is present in all orders of mammals. And it's really characterized by being very rapid and by being generally nonspecific. By this I mean it really responds to almost any insult to the host, and its response, of course, is very fast. And this is in contrast, for example, to the adaptive immune system. The adaptive immune system, of course, is what's responsible for the success of vaccination strategies, for example, and utilizes both T cells as well as antibodies. And while T cells and antibodies can be very, very specific and selective, they do take a while to mount an appropriate response, on the order of days to weeks. And this really is the contrast between the innate immune system and the adaptive immune system, the rapidity and the specificity of the response. Now, the innate immune system involves both circulating and tissue-resident cells. So this has some important implications when we think about people who might be immune compromised because of damage to their circulating immune system, and that's something we'll come back to later. In fact, if we think about this more carefully, the innate immune system is really responsible for defending the body and is actually quite active at all of the barriers between the host and its outside environment. So you can think of the guts, the lung, the oral mucosa, and even the skin as being very active in terms of the innate immune response. Now, 20 years ago, if anyone had said the words innate immunity, the answer would have been intrinsically inflammation. And that's because it was thought that the two could never be separated. However, over the last 20 years, we've begun to understand that there are the pathways that deal with tissue healing and bacterial clearance are in fact different from the pathways that deal with inflammation. And while we might not be able to separate these at the level of modulating the inputs to the innate immune system, by targeting an intracellular convergence point in the pathway, we can start to differentiate the responses of these pathways. Finally, it's important to think about how we modulate the innate immune system and the fact that the innate immune system has been fighting bacterial infections for millennia. This means that the bacteria really haven't been able to mount a very effective resistance to the innate immune system, and suggests that harnessing the innate immune response may act in tandem with antibiotics. And this is something we'll also discuss throughout the presentation. So when I talk about innate defense regulators, what exactly do I mean? Well, as I mentioned on the previous slide, the innate immune system is characterized by a relatively non-specific response. And it does this by recognizing some very common molecular patterns that are shared by lots of different pathogens, or, for instance, by indicators of tissue damage. And these different molecular patterns, be they pathogen-associated, or PAMPs, or damage-associated, known as DAMPs, really interact with innate immune receptors such as TLRs and NONs to kick off the innate immune response. Now, previous attempts to modulate the innate immune system have really focused on either targeting an input, think of something like a TLR agonist, for example, or an output, think of something like an anti-TNF drug, of the innate immune system. What differentiates the innate defense regulators is that they target an intracellular convergence point in the innate immune pathways. Now, you'll recall I mentioned that it is possible to differentiate the infection fighting and the inflammation aspects of the innate immune system, but you can't do that at the level of the receptors. Rather, you have to do that at the level of the intracellular signaling pathways. And what's interesting about the innate immune pathways is that they do tend to converge through relatively few convergence points within the cell. The innate defense regulators specifically target a convergence point that occurs around the protein known as P62 or sequestosome 1. And by targeting this convergence point, they actually change the balance of the downstream signaling pathways. So generally speaking, turning the innate immune system on results in both increased selective effector cell recruitment. For example, monocytes, macrophages, and neutrophils get recruited to the site of infection and aid in pathogen clearing and killing. Or you could, for instance, recruit macrophages to the site of tissue damage to aid in wound debridement and healing. In contrast, though, you can get some inflammatory signaling, such as TNF and IL-6, which results in inflammation. When we introduce the innate defense regulators, we cause more selective effector cell recruitment, and in fact this tends to be highly biased to the myeloid cells, while at the same time modulating inflammation. And I really use that term advisedly. Unlike some compounds that, for instance, might knock down TNF-alpha 90%, we will only knock down TNF by perhaps 30%. But it won't just be TNF. It'll also be IL-6 and IL-1, and at the same time anti-inflammatory markers like IL-1RA or TNFR2 will be increased, so that there's a whole shift in the innate immune response to a slightly more anti-inflammatory status. The innate defense regulators targeting P62 or sequestosome 1, it's actually more specific than that. The innate defense regulators actually bind specifically at the ZZ domain of the P62 protein. And the interesting thing about P62 is that it's not an enzyme. It's actually a scaffold protein, and what it's responsible for is bringing the players to the party that define what signaling networks get formed. When SGX-94 binds to the ZZ domain, we get increased complex formation with RIF1, and this causes increased P38 phosphorylation, as well as increased activation of the CEBP-beta transcription factor, which results in multiple downstream signaling pathways via the cytokines and chemokines. However, what SGX-94 does not do is bind to the PB1 domain of P62, and this means that it does not interfere with PKC zeta complex formation, and it does not alter how much the NF-kappa B transcription factor has been turned on. And this was also shown in independent in vitro studies. This is rather important because if you think of NF-kappa B as a transcription factor, you generally think of its action in an inflammatory context. So we can see here that by selectively altering the protein-protein interactions, we have a specific effect on the downstream signaling pathways. And this is one of the real advantages of the innate defense regulators and their mechanism of action. Of course, the other thing to realize with the innate defense regulators is that they're altering the downstream signaling pathways, and they're in fact rebalancing those pathways. They don't shut any one pathway down, but they emphasize some pathways over others. And if you think about the effect of that, you may actually expect in the long term that when there's competing pathways, there may in fact be a nonlinear dose-response relationship engendered. And that's something that we'll speak of more as we go through the presentation. However, if we take a broader picture and think about what it means to trigger these changes in the innate immune system, you can see that we have very broad spectrum, we'd expect broad spectrum activity with the innate defense regulators. Again, it doesn't matter what is recognized, if it's a gram-negative pathogen or a gram-positive pathogen, if the pathogen is extracellular or intracellular, or even if the pathogen is antibiotic sensitive or antibiotic resistant. They're still going to release those molecular patterns which are going to be sensed by the innate immune system, and the innate immune system is going to be turned on. Regardless of how it's turned on, the innate defense regulators still modulate the response because they're operating at those intracellular convergence points. Again, as I mentioned, the innate immune system is effective at a lot of different anatomic locations, and because it doesn't depend solely on, for instance, the circulating immune system, they can be active in immune-compromised animals as well. Just like I said that it doesn't matter what kind of pathogen triggers the innate immune system, it's actually true that you can also trigger the innate immune system to respond to tissue damage, and again, we would modulate those same pathways downstream. As I discussed earlier, we help to control the inflammation that comes out of that modulation of the innate immune system, and all of this means that there's an ability to enhance antibiotic action when antibiotics alone are suboptimal, either because they've been dosed at an incorrect level or because they're being used in the context of antibiotic resistance. And we'll show examples of many of these claims over the next few slides. So I spoke before about the innate defense regulators being anti-infective. And there have been innate immune modulators tested before that were found to be anti-infective, but only when administered prophylactically. And that had a lot to do with the fact that they turned on inflammation at the same time that they turned on the infection-clearing pathways. So what we needed to demonstrate firstly with the innate defense regulators is that we didn't just have prophylactic activity, which we absolutely do, but that there is also therapeutic activity as well. And this is shown on the left-hand slide graph with a gram-positive antibiotic-resistant bacteremia. So in this case it's MRSA, or methicillin-resistant Staph aureus, that's been administered directly into the bloodstream of the mice. And you can see that delivering the bacteria directly to the bloodstream starts to cause mortality relatively rapidly, with deaths occurring by 48 hours post-infection. Despite the fact that deaths occur within 48 hours, we can treat with SGX-9-4 as late as 24 hours after the infection and still alter the survival outcomes of the study. A similar example is shown on the right-hand side in a gram-negative leukopenic septicemia model. In this case, we're looking at rats, whereas in the left-hand side we were looking at mice. So these particular animals have been given antibiotics to disturb their gut microbiota. They've been rendered leukopenic through the use of cytotoxic agents. And they've also been given Pseudomonas via orogastric feeding. So basically their GI tract has been colonized with Pseudomonas. And as the bacteria continue to colonize, they release first endotoxin into the bloodstream, and then eventually the bacteria themselves are thought to translocate, ultimately resulting in septicemia. In this case, we don't treat with the SGX-9-4 until the fever has been symptomatically present, and that occurs on about day 5 post-infection. And a single treatment with SGX-9-4 on day 5 is able again to alter the survival outcomes in the study. So here we see evidence of that broad spectrum activity we talked of earlier with both the gram-positive and the gram-negative. Now, from a clinical perspective, you wouldn't expect to be treating in the absence of antibiotics. So this is an example with another gram-negative infection, Burkholderia pseudomallei. Now, Burkholderia is a saprophytic organism. It lives in the soil and in the water, and it's actually endemic in Thailand and northern Australia. And it is inherently very antibiotic resistant. In this particular model, which was done in mice, we gave the Burkholderia as an intranasal instillation, and this caused a lung infection followed by a septicemia. And what we can see here is that the doxycycline by itself was unable to treat the infection. However, when we added this SGX-9-4 to the doxycycline, we got a significant improvement in the survival window of these animals. So this is just to show again that the combination of the treatment of the innate defense regulators with the antibiotics can be particularly powerful. One of the other aspects, though, is not just survival, but what's happening to the bacteria itself, and can you in fact clear the infection. Here we've looked at two different scenarios. I'm going to give two different examples. On the left-hand side, we have a Staph aureus infection of the peritoneal cavity, where the only thing we're treating with is SGX-9-4, and we can see that there's a significant decrease in the bacterial count in the peritoneal cavity with SGX-9-4 treatment. And we'll come back to this peritoneal model in some of our other mechanism studies later in the presentation. On the right-hand side, we have a MRSA thigh infection model. Here you can see that when we use suboptimal doses of vancomycin, we do get some decrease in the bacterial count, and adding SGX-94 on top of that can decrease that bacterial count yet further, again demonstrating the power of the combination therapy. And one of the questions that, as I mentioned, we were wondering about fairly early on was what the anti-infective dose response would look like. Here we have a bacteremia model in nude mice, and you can see that as we increase the dose level, we do get progressively better responses. And in fact, we've generally found that the best responses occur between about 25 and 50 mg per kg in a mouse, which is about 2 to 4 mg per kg in a human. However, we generally can't dose higher than about 60 mg per kg in a mouse just due to issues with small furry animals. So one of the questions that must arise is how do the innate defense regulators such as SGX-94 cause this effect, this increased bacterial virulence and this increased survival? And what we found by looking specifically at the site of infection in a peritoneal cavity is that one of the effects we see is an increased recruitment of macrophages to the site of infection. Interestingly, though, the neutrophils are not increased dramatically at the site of infection, and this is important because the neutrophils are generally considered more of the inflammatory response. In fact, we found that if we actually poison the myeloid-derived cells with a poison known as clodronate, and then try and have the SGX-94 or innate defense regulators treat an infection, they don't work as well. Their activity is strongly abrogated. And this certainly does suggest that it's very important to be able to recruit these myeloid-derived cells to the site of infection. Back and ask the question, well, how did those macrophages get recruited there in the first place? And here we see that when we look at 3 hours after the infection, we actually see an increase in some of the important chemokines that call cells to the site of infection, responding to the SGX-94 treatment. So in this case, the chemokines are RANTES and IP10. And in fact, we can also then look later and ask what happens to the inflammatory response. And on the left-hand side, you can see that at 24 hours after the infection in this same peritoneal cavity, we go from having rather significant TNF levels in some animals to very low TNF alpha levels in that same peritoneal cavities when the animals are treated with SGX-94. Now, as I mentioned, it's not just the inflammation by TNF alpha which is being affected by the innate defense regulators. And this is shown on the right-hand side, where we've given mice an LPS challenge directly to their lungs, and we've looked to see what the response in the lung fluid is. And here we can see that the anti-inflammatory marker IL-1RA is significantly increased with SGX-94 treatment. So this is just a reminder that the response in terms of the inflammatory state of the individual goes beyond any one cytokine or chemokine. Now, I mentioned earlier that the impact of the innate defense regulators isn't completely mediated by the circulating cells, and in absence of a strong circulating immune system, we can still have tissue-mediated effects. And some of the evidence I showed you of this in previous slides were, for instance, the model where we rendered the animals leukopenic, or, for instance, the model where we conducted the study in nude mice which are athymic, so they don't have functioning T cells. However, this is another approach to trying to understand this question. And here what we did was we really excised the spleen from mice. And we took those spleens and we incubated them with the innate defense regulator. And then we added LPS to the mix. And then we let the spleens respond to that mixture overnight. Now, an important thing that I haven't mentioned thus far is that the innate defense regulators are really small peptides, 5 amino acids, 6 amino acids long, and composed of all L amino acids, generally speaking. And this means that they degrade extremely rapidly, within minutes, when they're subjected to tissue proteases and peptidases, such as those that would be in any mixture of spleen cells or in any circulating blood system. So the innate defense regulators themselves have a very short pharmacokinetic half-life, but their pharmacodynamic effect is enduring, and we're going to show that as well in this experiment. So as I said, we incubate the spleen cells overnight with the innate defense regulators, and by the next day, all the innate defense regulators are gone because they've been degraded by the proteases and peptidases. We then take the conditioned media off the spleen cells and we put them onto some macrophage cells. So the raw cell is a mouse macrophage-like cell line. And we ask, how are the raw cells going to respond to the differences in the conditioned media that were induced by the innate defense regulator? And we look at that by evaluating a couple of cytokines, such as IL-6 and TNF-alpha. So again here we see that, for instance, treatment with the SGX-94 results in a statistically significant decrease in both of these inflammatory markers, IL-6 and TNF-alpha. Perhaps more interestingly, when we use other innate defense regulator compounds that we know bind not very well at all to P62 or better to P62, we see corresponding changes in the anti-inflammatory response in these cells. So here we see a direct correlation between binding to the target protein P62 and the ultimate outcome of this tissue-mediated effect. So as I mentioned earlier, one of the points about rebalancing the innate immune system is that you might expect that there would be a nonlinear dose response. And while we didn't see this in our early studies, particularly in mice, because there was a limitation to how high we could dose, when we went into primates and especially looked at anti-inflammatory markers, we did start to see evidence of a nonlinear dose response. That is, the response to the innate defense regulator SGX-94 was more anti-inflammatory at low doses and less anti-inflammatory and more placebo-like at higher doses. And this is a point that we're going to come back to with some of our discussions of our clinical studies. But before we do that, we need to take a step back and talk about another way which the innate immune system responds to stimulation. So I mentioned earlier that it really doesn't matter what turns on the innate immune system, we still modulate the response, and that could be anything from an infection to tissue damage. And in point of fact, there is a very important indication that's associated with the innate immune response to tissue damage, and that's oral mucositis. Mucositis is a debilitating side effect of cancer chemotherapy and radiation therapy. It's actually one of the most severe side effects. It can cause patients to be unable to eat or drink because the pain in their mouth is so bad, and it can actually result in the patients stopping their underlying tumor treatment regimen, which clearly has a negative impact on survival, in addition to introducing a lot of different side effects which can result in their having to be hospitalized and issues of that nature. So what is oral mucositis? Well, if you think about it, initially you give radiation and chemotherapy, and obviously the idea is to target the tumor cells. There is, of course, some damage to the normal tissue as well, and irrespective of what's damaged, there are damage-associated molecular patterns, or DAMPs, that are released, and the innate immune system responds to that damage. Unfortunately, the response, especially if it's a strongly inflammatory response, can really exacerbate the underlying damage, causing even more overt ulceration. That ulceration can then yield a portal of entry for infection, which becomes an important secondary consideration in the oral mucositis. And then eventually, of course, there has to be tissue healing. Now, all of these steps, the initial over response of the innate immune system, the infective and ulceration issue, and then, of course, the tissue healing, are all related to the response of the innate immune system. And this has led to the theory that mucositis is really strongly driven by the innate immune response. So we looked at this in two types of animal models to begin with. The first was a radiation-induced mucositis. This is shown on the left-hand side. What's done here is we give 4 days of radiation to the mouth of the hamster in this case, followed by a weekend break, and then another 4 days of radiation. And this is very similar to the type of treatment regimen that head and neck cancer patients, for example, would undergo. And here we can see that treatment with the SGX-94 really decreased the duration of oral mucositis by 50%. We can do the same thing where the oral mucositis is caused by chemotherapy. Again, from the point of view of innate defense regulator, it shouldn't matter what causes the damage, so long as the damage is caused. So in this case, the chemotherapy causes both an oral mucositis as well as impact in the lower gastrointestinal tract. And in this case, again, we see a 50% reduction in the duration of oral mucositis, both from the oral component as well as from the point of view of colitis. Interesting things that we can study in this is this enduring pharmacodynamic effect I talked about. So again, very rapid PK for these compounds, and that's, of course, completely in line with the chemical nature of the compounds. But this is not a problem in the context of the innate defense regulators, because really their primary job is to trigger a change in the innate immune system. And we've actually demonstrated in our infection models that treatment up to 5 days prior to infection is effective. But of course, we're not really interested in prophylactic treatment from a clinical scenario, and so we needed to ask, how often should we dose the compound? And we looked at this in two different ways. On the left-hand side, you can see a gram-positive antibiotic-resistant bacteremia, again with MRSA here. And you can see that when we treat twice within a 24-hour window, the blue and the black lines are really not that different. There was no added benefit from dosing within 24 hours a second time. This suggests that that initial dose of SGX-94 triggered a change in the innate defense system, and that change is still enduring, and no further change can be triggered. But when we space the dosing out more, say 48 to 72 hours, we start to see evidence of a potential added benefit. Now, this is very difficult to study in the context of an acute infection model, and more easily studied in the context of an oral mucositis model, which is what you see on the right-hand side. Again, here we find that when we treat on every third day of radiation instead of daily, we get the best response to SGX-94, again suggesting that a daily treatment is certainly not needed, and treatment every second or third day is sufficient. So at this point, the question becomes, how will we translate this to the clinic? Now, we expected very good translation to the clinic on the basis of our understanding of the innate immune system. Again, as I stated earlier, the innate immune system is present in all orders of mammals, and the responses tend to be highly conserved. Not only is the innate immune system in general highly conserved, but the target protein we're interacting with, P62 or sequestosome 1, is also very highly conserved, with 91% sequence identity between mouse and human, and 99% sequence identity between orangutan and human. So what we decided to do was bring these compounds forward to clinical studies, and initially we decided to focus in the oral mucositis setting because clearly infectious disease requires a significantly larger clinical trials. So we did a phase 1 study in 84 healthy volunteers, which demonstrated that SGX-94 was very well tolerated, and we'll describe some of these studies in more detail in the next slides. And then we have just completed a phase 2 study in 111 head and neck cancer patients at risk for severe oral mucositis. And from the point of view of understanding how the innate defense regulators work, the most important finding in these studies was that we had complete concordance between our non-clinical and clinical. So when we did our phase 1 study, one of the questions we had to ask was, of course, about the safety of immune modulation. And this was in the framework of other immune modulators that had more surprising results in their phase 1 study. So when we did the phase 1 study in the healthy human volunteers, what we did was we collected blood at various time points post-dosing, and then we took the blood out and stimulated just the blood with endotoxin. The idea being to make sure that the innate defense regulators hadn't made people more susceptible to a septic response. Now, clearly from our preclinical work, this was not what we expected. We would have expected an anti-inflammatory response, but equally clearly, it's better safe than sorry. So when we did this, we took a look again at a variety of different markers at a variety of different time points post-treatment. And what we found was that, again, we saw this shift to this more anti-inflammatory state. So on the graph to the far left, here we're looking at the ratio between the anti-inflammatory marker IL-1RA and its partner inflammatory marker IL-1 beta. And you can see that there's a synergistic shift to a more anti-inflammatory state especially with patients that had received the low dose of SGX-94 between 0.15 and 2 mg per kg. When that dose was further increased to between 3 and 8 mg per kg, this response fell back and began to look much more like placebo. And this again was consistent with some of our earlier studies, especially with those we had seen in the primate. In fact, again, it wasn't just the IL-1RA over IL-1 beta ratio where we saw this effect. We also saw it in the ratio of TNFR2, which is anti-inflammatory, to TNF-alpha, inflammatory, again with a shift to a more anti-inflammatory state at the low dose. And in fact, when we looked again at 96 hours, we saw this same ratio was still shifted. So again, there was this sustained and enduring pharmacodynamic effect that we had seen in animals replicated in the human clinical setting. A phase 2 study in oral mucositis. And as I mentioned earlier, these really focused on head and neck cancer patients that had been planned to receive at least 55 gray of radiation and either weekly or every third week cisplatin. So these patients, they receive radiation therapy for 5 days a week for 7 weeks. And we treated with the SGX-94 just twice a week throughout that whole radiation treatment window. And what we found, as shown on the left-hand side, is that again we saw a 50% reduction in the duration of severe oral mucositis in these patients. So again, very consistent with our previous animal work. And here we had really gone in and tested with 2 different dose levels. One at 1.5 mg per kg, which was really right in the middle of the low dose range we had seen a response for in our phase 1 study. So between 0.15 and 2, we had seen this increased anti-inflammatory response. And because inflammation is the major driver of oral mucositis, we thought this would be a very important dose level to test. So we went in at 1.5 mg per kg. And then to confirm the findings from the phase 1 study, we also took a higher dose, the 6 mg per kg dose, which was well within the high dose range where we had seen a more placebo-like response. So this 50% reduction we see in the severe oral mucositis was really seen very clearly at the 1.5 mg per kg dose. At the 6 mg per kg dose level, the response was much more inconsistent and it wasn't really a 50% reduction either. So it was clear that the 1.5 mg per kg dose was the more effective dose in the context of oral mucositis. Again, very consistent with our phase 1 results and even with some of our preclinical work where we were really looking at the anti-inflammatory response. Now, not only did we see this 50% reduction, but when we looked at the patient population that was specifically at very high risk for severe oral mucositis, we actually found an even further reduction, a 67% reduction in the duration of severe oral mucositis in that patient population. In the oral mucositis study, one of the things we were able to do was monitor infections that had been recorded as adverse events. So clearly infections are important adverse events, especially in patients undergoing chemoradiation therapy. And these infections were recorded across the board, so it didn't matter if they were fungal infections or bacterial infections, and all concomitant antibiotic and antifungal treatments were allowed on the study. So this is really a very broad spectrum of infections that were considered. And when we looked at all infections in the study, we found that both the 1.5 and 6.0 mg per kg dose levels of SGX-94 showed a markedly reduced rate of infection compared to the placebo patients. Not only that, but when we focused down onto the non-fungal infections, which would mean the bacterial infections, we again saw a significantly reduced rate with SGX-94 treatment at either the 1.5 or 6.0 mg per kg dose levels. This really suggested that anti-infective effect that we had seen preclinically in the animal models was again recapitulated in this human clinical setting. What does this mean from the point of view of infectious disease? Well, it means that when we interact with the innate immune system, we have the potential to target bacterial infections in a very broad spectrum manner. This means that you wouldn't have to identify the pathogen positively before starting treatment, and that any treatment you gave would likely be effective irrespective of whether there was any antibiotic resistance in the pathogen population. And finally, because the innate immune system, at least, is active in both the tissues and the circulating cells, these treatments will work in at-risk populations, including those who are immune compromised. Perhaps even more interestingly, this method of treatment can be combined with the standard of care antibiotic therapy. In fact, we've already tested for interference with most major antibiotic classes and found that there is none. In fact, in general, there's not likely to be much PK interference with other drugs, because where other drugs may require kidney or liver function to be metabolized and degraded, the innate defense regulators are handled by the blood and tissue peptidases independent of any kidney or liver function. So, from the point of view of where we are today in terms of the innate defense regulator program, clearly there's been a phase 2 study in oral mucositis completed, and a phase 3 clinical study is initiating in 2017. Clearly, to support those studies, CGMP quality drug products already available. The pharmacokinetic and non-clinical toxicology package has been completed, as have the phase 1 healthy volunteer studies. And of course, there is also a portfolio of IDR analogs, complete with a co-crystal structure which has been solved for SGX-94 in its target binding site and an associated structure-activity relationship. So in conclusion, I'd like to say that the innate defense regulators, such as SGX-94, represent a new class of compound that have a unique mechanism of action that target an intracellular convergence point in the innate immune signaling pathways. Because of their unique mechanism, antibiotics may significantly enhance antibiotic efficacy without increasing resistance, and certainly don't interfere with antibiotic action on either a pharmacodynamic or a pharmacokinetic basis. Moreover, IDRs are truly broad spectrum. They can act independent of what the bacterial pathogen characteristics are, and they target both tissue-mediated and circulating innate immune responses, meaning they can be active despite some level of compromise in the host innate immune system. And finally, despite their very rapid pharmacokinetics, the innate defense regulators have extended pharmacodynamic action. The fact that we've seen such a high degree of clinical translation in our recent phase 1 and 2 clinical studies certainly suggests that all of our other non-clinical findings will translate equally well to the clinical setting, and strongly position the innate defense regulators for further development in the area of infectious disease. There's been a lot of work in understanding how the innate immune system works and the use of these innate defense regulators, and that work's been done over a number of years with a number of different collaborators. I'd like, however, to specifically acknowledge the University of British Columbia for the work with regard to the infectious disease space, and the Harvard Cancer Center for the work with respect to oral mucositis. And finally, also, I'd like to acknowledge funding that we received from the National Institutes of Health. Thank you, and I'd be happy to take any questions.